Hey guys, I guess it's been really long since we've had a lecture, and today is going to be a lecture on something as simple as anesthesia. And I do not directly want to jump into the anesthetic drugs and all of that for the heck of it. First, I want to get into a classical uh, method of giving anesthesia in a patient, and what do you do as a pre-op, during op, and even post-op. Right. As much as people say it is a part of surgery to do pre-op, op, and post-op, it's a part of anesthesia as well. Right. So first of all, what are we supposed to do? I'm so sorry. First of all, what are we supposed to do? First, we need to see the following things. Okay. We need to do a pre-anesthetic checkup, right? And a pre-anesthetic checkup involves hypertension. So how much do you want your hypertension? All right. You have a pre-anesthetic checkup, right? You have a pre-anesthetic checkup. In that, you want to check for hypertension. You want to check for it to be from anything. It should be around your normal physiological, right? I'm keeping your map mean arterial pressure at around 130. Now, sometimes when your hypertension is around 180 by 130, that is, you're in a hypertensive state, right? So you do not want to do surgery. You contraindicate it at this point because there is a high risk of bleeding. Second is that when there is high risk of bleeding, it kind of drops to 90 to 50, all right, when there is bleed because of bleed. And once the bleed has occurred, the BP drops to 90 by 50. And once it's at 90 by 50, there is hypoperfusion. Now, there are a few organs in our body which is specifically to speak, it's CNS, renal, and even the heart. All of them have auto-regulation. At a BP of 90 by 50, auto-regulation completely fails. So that is why you cannot get a surgery done at 180 by 130. So when do you get a surgery done? You get a surgery done when it's anything less than 140, or even a 160 is fine, as long as you're at a range of between 50 by 150, where your auto-regulation of the heart can occur. Right? Now, speaking about the drugs that you could use for hypertension, you should use CCBs most commonly because there's less risk of postural hypertension. Sometimes something like an ACE works well, but you need to discontinue this 1 day before the surgery, right? Because they can cause postural hypertension, right? So you discontinue this till the day of surgery. So not 1 day before. Let's say if the surgery is on Monday, you even take it on Sunday, but you do not take it on Monday, right? So that means till the day of surgery, right? Now, ACE, ARB, and a nitroglycerin, all of these have the same high postural hypertension. Now, if there is a case of DM, right, what do you want to know about the diabetes mellitus? Diabetes mellitus, you do not want to do a surgery if your blood sugar, obviously you could do a surgery in most cases, but you do not want to do it specifically when your blood sugar is around 450, right? When it's about 450, anything which is really high, you do not want to do it because it promotes infection, specifically all these opportunistic infections that hit through. Second, you do not want to also insulinate the patient, which will lead to hypoglycemia, and eventually, it's obviously going to cause a lot of shock-like features, syncope and whatnot. But hypoglycemia would not be easily picked up as well, because you've been given anesthesia. So hypoglycemia, even if the patient occurs, the trembling and all of it would not really be seen. So you need to specifically manage this 450, and you want to give insulin. Obviously, you want to give insulin, and then you also want to give oral hypoglycemic agents. Now, if it's a DM1, you are putting the patient on insulin, definitely. And DM2 also, sometimes you might have to put the patient on insulin, right? If your HbA1c is greater than 7.58, you need to definitely put the patient on insulin. So the thing that it boils down to is that in your DM1, if you're putting the patient on surgery, your insulin has to go down by 1:3, right? Because you might put the patient in a hypoglycemic coma, right? You do not want that as well. And if it's a DM2, you just need to halve the dose, right? You don't even need to 1/3 the dose, you need to halve the dose. Okay, And during surgery, you want to maintain your glucose level at somewhat. You want to maintain your glucose level during surgery. During surgery, you want to maintain it around 120 to 200. All right, you do not want to go uh, too low. You do not want to go too high. Too low is also bad, right? But uh, glucose is not a very big factor when you're doing a surgery, because 120 to 200 is a big range that you have, and you've got a lot of things. Okay. Now, epilepsy. Sometimes it's propagated by hypoxia, hypercapnia, and acidosis. So it might just end up in a status epilepticus. So you can optimize it by giving anti-epileptic drugs, but they should be discontinued. Discontinue anti-epileptics. Obviously, it's only in a known case of an epileptic patient you give anti-epileptics, right? But it is discontinued. It's discontinued. And when is it done? That it's discontinued on the day of surgery, right? Till the day of surgery, you definitely have to go for it. All right. uh, some anti-epileptics actually ruin the LFT, so you need to check for the LFT, and you make sure that the LFT is fine. Sometimes you do not also want to use as something as potent as enflurane, desflurane. All of these are inhalational, and you do not even want to use methhexital. They all should be avoided, right? Thyroid disorders also need to be checked in place, because your thyroid, you do not you actually want to see if your TSH is high or low. You want to check for basal metabolic rate. If your basal metabolic rate is really high, you're probably hypothyroid, and in that case you need to give your anti-thyroid drugs. You know about the anti-thyroid drugs. I do not need to get into it. If your basal metabolic rate is really low, you need to give a thyroxine supplementation, right? You need to give 1 microgram per kg thyroxine, levothyroxine, right? So you continue that as well. Now, sometimes you also have a patient who comes with psychiatric problems, and you know about that is that you need to continue this. Even you need to continue this, all right, even on the day of surgery, because if you withdraw the psychiatric drugs, it might just precipitate this episode. What you do not need to continue is your MAO inhibitors. Why? Because when you are usually doing a surgery, you might need to give the patient a morphine, right, or morphine like drugs. So MAO B, especially salicyline, and MAO A's, right, they specifically uh, decrease, or they react with the opioids, mepridine, and they can actually they can cause elevated levels of mepridine, and even your catecholamines, right? So you would have a SNS storm, right? So that is one. Then lithium, if it's lithium and magnesium as well, all right? Lithium, magnesium, they are also contraindicated, all right, with muscle relaxers, right? You cannot give it, so you need to stop it 24 hours prior giving a muscle relaxant, right? Because they will obviously interact with the muscle relaxers. But nowadays we've got these two muscle relaxers, cis atracurium and atracurium. They're so quickly acting that they're really good, all right? So you might not need to stop lithium, right? Lithium you want to give for bipolar and suicidal ideation, right? We know about that. We do know about that. And we know about the side effects of lithium as well, so obviously. A patient comes with MI and stroke, so what do you want to do? You want to, with the prior history of MI, so when there's a prior history of MI, there's a prior history of stroke or an MI, you might have been taking aspirin, clopidogrel, beta blockers, ACE inhibitors. So you have to stop your clopi, all right? You need to stop at 7 days. Aspirin you need to continue, but if it's a severe surgery, all right, continue it. But if it's a severe surgery, then you might need to stop 3 days before, if you're suspecting a lot of bleed. Clopidogrel, ticagrelor, something apixaban, all right. Apixaban is actually good. Apixaban is such a good drug because you can continue 24 to 48 hours. Just discontinue 24 to 48 hours. So yes, that is a good drug. And diprimidol, 24 hours. But all of these drugs are not really going to be used that commonly, right? We know that. And it's a fact, right? So you keep that in mind as well. If you're just giving a topical anesthesia, you do not. So there are a few questions that have been asked, right? A patient has been, you want to take him for cataract surgery, and you probably want to know if you can keep the warfarin on or not. So obviously, if it's topical surgery, do not discontinue your warfarin. There's no fear of bleeding. It's a cataract surgery. You're just giving a peribulbar block or a retrobulbar. You don't even need to give a retrobulbar, right? So you give a peribulbar block and you're just done with the cataract surgery, right? So it's a daycare surgery. You don't need to block or you don't need to stop warfarin. Okay, again, if there's a female, she's on OCPs, and you're pushing, or she's getting a herniatomy or a hernioplasty. All right. Do we need to stop the OCPs? Well, you're not supposed to stop the OCPs because OCPs are going to increase the risks of DVTs, but they're not going to cause bleeding, right? And if there's a risk of DVTs, then you might need to stop the OCPs, right? For that, you need to do your well score. But it's not necessary to even do a well score because sometimes you just know if the patient is on a DVT. If she's taken an OCP, she's 30 years old. There's a low chance that she's on, if her BMI is within the normal range, you don't suspect that there's going to be risk of DVT, there's no need to stop an OCP. Coming next, if there's a patient who's on an ATT, antituberculous therapy, and you're getting a surgery done, do you need to stop the ATTs? No, you do not need to stop the ATTs. You just need to get an LFT done, all right? You just want to see if your enzymes are normal. If they're not normal, obviously you might need to get into getting the ATTs lowered down, tapered down, and then get the procedure done. If it is a invasive procedure, if it's something that is more daycare and very simple, you do not need to even taper. Patients on steroids, all right, if there's an abrupt stoppage of steroid, you might need to give your hydrocort, and you need to keep that patient up, all right? Patient on any Ayurvedic, they are so strong Ayurvedics that actually damage the LFTs and PT and PTT, all right? So you need to do an LFT before that patient who is on an Ayurvedic medication actually comes to you, right? Patients on NSAIDs, you can continue your NSAIDs to 24 to 48 hours, but you need to stop it in case you're doing a surgery, right? Sildenafil, again, you need to stop it from 24 hours prior surgery. Diuretics, all diuretics need to be stopped 24 hours prior, but except one, that is thiazide. Antiretroviral, you need to check LFTs again, you need to check for hepatotoxicities, hyperlipidemias, cardiac conduction, and even sometimes renal. You need to make sure that your GFR is good because most of them are not given in lenient failures as well, abacavir and all. When do we tell the patient to stop smoking? All of these are just basic things, but they are asked. All right, you stop smoking 6 to 8 weeks, all right, prior. You need to, because you don't want that laryngospasm to occur, right? In case there is a laryngospasm, what do you need to do? You need to give succinylcholine, all right? A succinylcholine is a short-acting muscle relaxant. You need to do a jaw thrust. You need to give succinylcholine. You need to give propofol. And you need to intubate, all right? One more important thing is that propofol, instead of propofol, a lot of people also use Midaz, right? Midazolam. It also works well. It's just that propofol is much more patent. It is really good. Works wonders. Correct. If there is a patient who is already on methadone or naltrexone or disulfiram because he had alcohol withdrawal symptoms or morphine, and he was addicted to cocaine and morphine, and sorry, not cocaine but definitely morphine, heroin, all right? So if you're on methadone, you need to continue methadone, all right? If you're on naltrexone, just decontinue like 3 days before surgery, because you're not going to have a good response to opioids. You might have to use opioids in these patients. Obviously, some of them also ask you to not use a strong opioid for pain medication, and then you're just left with NSAIDs. and he might just have to push for something very strong in NSAIDs, diclo or ketorolac. But yes, sometimes people are so headstrong, and that's respectable completely. And disulfiram is again for alcohol. I mean, it's just going to cause vomiting, so you don't want to do disulfiram. You can give the patient an off for 10 days, right? You stop disulfiram completely. um, After that, you want to know the investigations that you want to do before surgery. If you want to know the investigations to do before surgery, you do a CBC, check for hemo. It shouldn't be less than 8. Shouldn't be. So you contraindicate it. The surgery, your total leukocyte count, if it's like really high, around 15k, again, you don't want to do the surgery. Find out why is there an infection. RFT, find out what's your creat, what's your urea. Is it high, is it low? Do a urea by creat, serum urea by creat. Find out where if it's greater than 20, less than 20, where the block is. All of this is hardcore medicine. Watch the medicine video to understand what is the greater than 20, less than 20, or a first aid. Just open the first aid and check it out. Check for serum electrolytes, obviously. Electrolytes. Right, electrolytes. Check for potassium. If its potassium is high, you're looking at a hyperkalemia. What do you want to do? You do not want to do the surgery. Get the potassium in control. Put him on something as simple as a sevelamer, something as a not sevelamer, any potassium binder actually. Caxylate. Put him on caxylate. And also lower the potassium by giving him insulin. All right. Okay, LFTs. Check what is your coax studies. Check your PT, INR, PTT. Is it greater than 1.5 INR? Oh, no, bad. All right. ECG. Check for any MI. Check for any prior history. Check for any fibs. If there's an issue, you might not be able to get the surgery done. If there's a fibrillation, get that fibrillation under control. Do a rate control, get a rhythm control. Which one? Get a rhythm control. If it's unstable, get a rate control. Obviously, this patient is not unstable because it's a pre-op evaluation that we're looking at. CXR, look for any consolidated foci. Needed, not needed. Check it out. Cardiac evaluation. If it's an emergency surgery, you do not need to do a cardiac evaluation. If it's an urgent surgery that requires operation within 6 to 24 hours, you do not need. But if it's a time surgery, get a 2D echo, get a get an ECG, get a serial monitoring, if there was always an acute cardiac condition, get a trop, get an ECG, get a trop. Always figure that out. Least criteria, there's something called as the least criteria. Least criteria is what? A point for every risk factor for a cardiac index. If it's in high risk surgery, you get 1 point. If it's a history of ischemic, high risk, ischemic heart disease, congestive heart failure, cerebrovascular accident, a DM, a creat greater than 2, all of these get 1 point each, right? So 1 1 1 1 1. That's a least criteria. Step 4, assess the functional capacity. Functional capacity has to be the amount of metabolic equivalent, right? Metabolic equivalent of task. That's a MET. So rate of energy consumption. So 1 MET is equal to 3.5. A functional capacity about greater than 4 MET is good. A functional capacity less than 4 MET is, again, it's not that it's bad, but functional capacity you want. So the idea is that greater the functional capacity, greater is your functioning of the heart, right? And your functional capacity has to be around 4 METs. Your BNP has to be low, and your pro BNP also has to be low, like around less than 92, and your pro BNP around 300. All right. So that is one. Always do your stress testing. If there's a low functional capacity, get your enzyme studies. Okay. Now, very importantly, people have asked this a lot. If there's a coronary stent which was placed, when do we do an elective surgery? Emergency, you have to go for it. What kind of a stent? Metallic drug-eluting stent. Drug-eluting stent, give for 6 months, you need to take aspirin, all right? And for almost 6 months to a year, you need to take antiplatelets, aspirin, and clopidogrel. But if it's a metallic stent, all right, you need antiplatelets for 30 days, all right? Require for 30 days. And then you can directly go for a surgery, but sometimes you have to wait for 6 months or 30 days, depends. Now you need to figure that out. If there's a pacemaker, you definitely don't want to use your unipolar cautery. You need to use your bipolar cautery. That's again easy. When to administer infective endocarditis prophylaxis? In case there's a case of infective endocarditis, you suspect or you are suspecting that that person will develop infective endocarditis, 2 gram of amoxicillin. 2 gram of amoxicillin you want to give when? If there's a previous history, if there's a prosthetic valve, if there was a cyanotic heart disease, a repaired cyanotic heart disease, a cardiac transplant. All of these cases you want to go for a simple shit. Alright, upper respiratory tract infection, we check the CXR, wait for 4 weeks. If it's an obstructive lung disease, just do an ABG CXR. You can go for a CT to confirm it, but you do not need to do it. Or LD, a restrictive lung disease, you do not need to do a PFT. Just continue. Alright, for only for lung surgeries you might need to get a PFT. CNS. CVA. If there's a patient of CVA, you need to wait for 9 months. Alright, a cerebrovascular accident, wait for 9 months. Alright, for any non-emergency surgery. You need to continue aspirin, does not matter. Do not stop the 3-day rule. You might have to stop the clopidogrel for 7 days, but just continue the aspirin forever and ever and ever. Amen. Alright, if there's a surgical aortic valve replacement, you can do it other than 3 months before. So that's the only exception, where if it's an aortic or valve replacement, alright, you can do it. So that is about what you need to do as a pre-op. Alright, and another few things. What do you want to do as a pre-medication? Pre-medication, you definitely want to give anti-anxiety like your Alpraz and your Midas and any short-acting benzos. For a matter of fact, you want to give something as an anticholinergic because you don't want bradycardia. You also don't want the secretions to increase. So you give something. You give a really good one, which is a glycopyrrolate, or you can also give atropine. Depends. All right, you do not want the child to have less than 60 brady, so that's why it's good. When do you want to stop the food? For an adult, you want to stop the food for like 6 to 8 hours, right, prior surgery. For a child, you definitely want to start for 2 to 4 hours. You do not want him to have any clear liquid. 4 hours and no breast milk. All right, and 6 hours, like you for solid food. All right, and 8 is for like heavy fat meal. All right, so 2 4 6 8, and this is 6. So 2 to 4 hours, no water. 4 hours, no milk, no breast milk. 6 hours, light food and heavy fat meal. All right, that's good. Emergency surgery, sometimes you can't do anything. If it's an emergency, put a rice tube, get a metoclopropamide, get even also Omi and Rani, get an omeprazole and put on ranitidine. And also you can give a sodium citrate of 0.3 moles. Why you want to give sodium citrate? Citrate is just going to kind of neutralize all the acid. All right, to reduce infection, you might have to give antibiotics for our golden period. If you know about it, in case of C-section, you have to give 30 to 60 minutes. A lot of surgery, you need to give 30 to 60 minutes before the surgery. This post-op was for our golden period. Dexamethasone and ondansetron is for nauseatics, right? Opioids and general anesthesia can stimulate nausea, so you want to give ondan and dexa. All right. Predictors of difficult airways are going to be obstructive sleep apnea, right? Malampati 4, and I think everyone knows about Malampati, right? Malampati is so high yield. Okay, 1 2 3 4, right? Ovula, everything visible. Ovula not visible. 3 is slight soft palate, all right, and ovula seen, and only portion of ovula seen. How to test if the patient has a difficult airway or not? Your thyromental this distance has to be less than 6 centimeter. Sternomental distance has to be less than 12.5 centimeter, and you cannot protrude the mandible. All right, so thyromental and sternomental 12.5 6.5. Just remember this. All right, this is high yield. And what are the drugs that you continued on the day of surgery? All antihypertensives. All right, antihypertensives except ACE and all. Antithyroid. All right. steroids, antipsychotics, all right, anticonvulsants, asthmatic drugs, statins, diuretics. You stop, but let's keep thiazide here. That's about it, right? So sildenafil you stop 24 to 48 hours. You can stop diuretics except thiazide. You can stop oral hypoglycemics, right? And I think that is about it, right? CNS. Then the next thing that we have to actually get into is CNS monitoring. We see that in the next lecture, right? We'll see that in the next lecture for sure. But just to remember, just to recap a little bit about the when do you stop, when do you not stop. Sildenafil 24 to 48 hours, NSAIDs 24 to 48 hours, diuretics 24 hours, right? You stop all of these, and the rest you just continue. Statins, levodopa, yep, L-dopa, so you can continue. Antidepressants, you continue. Beta blockers, digoxin, you can continue till the day of surgery, obviously. So that is pre-anesthetic checkup, right? Now we'll get into the CNS CVS monitoring, right? How you want to monitor during the episode, during anesthesia, or once the patient has been intubated. That's going to be the next topic that we are going to actually get into and look into hardcore, right? And after that, we're going to see the different types of anesthesia: spinal, peripheral nerve block, central itself, right? We'll do that. See ya.